Hello, it's great to be back, and I'll talk about diagnosis and management of ARVC. What have we learned in the past 22 years that we've had this program at Hopkins? The outline is here. So I think we're all aware that ARVC is a genetically determined cardiomyopathy characterized by progressive replacement of right ventricular myocardium with fatty and fibrous tissue, and clinically by ventricular arrhythmias of right ventricular origin. We're also keenly aware that a left-dominant form of ARVD has been described, leading some to call this disease arrhythmogenic cardiomyopathy. Now, this is the heart of a 32-year-old who was transplanted for ARVD. The right ventricle shown here is very dilated and thin, and the wall is replaced with fat. The left ventricle is essentially normal. This is an uncommon disease, about 1 per 5,000 in the US. About the same prevalence in men and women, counts for about 20% of sudden deaths in Italy and 5% in the US. So when a young person dies, it's one of the top 2 or 3 things that are found on autopsy. When it comes to diagnosis, we rely on the 2010 diagnostic criteria developed by Frank Marcus. Many of us were on the writing committee. The point of this slide is to remind you that the diagnosis is complex. You have to look at many different test results, the EKG, the Holter monitor, the family history, biopsy if you have it, RV imaging, and so forth. And there's a number of criteria that we look at to make the diagnosis. This is an EKG of a patient with ARVD. I don't expect any of you to be cardiologists, but when we say T-wave inversion, lead V1 to V3, that's what we're talking about, lead V1, V2, and V3. That's a major criteria. This slide also shows terminal activation delay, shown here from this bottom of this QRS complex back to baseline, is prolonged. MRI is a great way to look at RV size and function. It also is a great way to look at LV size and function, to look for wall motion abnormalities. And it also allows us to look for fat and scars, so it's considered the best imaging tool for ARVC. But it's also the most common reason that ARVD is overdiagnosed or misdiagnosed. And that's because, one, people are not aware of the diagnostic criteria. They think that MRI is the gold standard, which it's not. They often don't realize that fat in an MRI can be normal. That doesn't mean ARVD, and so forth. Also a pectus. If you have a deformity of your sternal bone, that can make your RV work funny, and people can think it's ARVD. So the point is, it's just one test. You've got to look at all the other tests together with it, and you need an expert person interpreting the results of the MRI. Now, when it comes to genetics, up to 2/3 of patients have a mutation in a desmosomal protein. The desmosomes are the proteins that hook the heart cells together one to the next, and they're listed here. And that's and the genetic abnormalities we find are most commonly in these desmosomal proteins. You'll hear the names plakophilin-2, desmoglin, desmoplakin, desmocolin, plakoglobin, all desmosomal genes. There's some non-desmosomal causes that are shown below, but those are less common. And when it comes time to clinical presentation and follow-up, we'll look at some of our prior data. This is a study from 15 years ago, 100 patients with ARVD diagnosed either on autopsy after dying with the disease or alive. You can see the average age of diagnosis was 29, with half men, half women, half highly athletic, and they presented with palpitations, syncope, or sudden cardiac death. This shows their clinical course. You never see abnormalities before puberty. Then VT starts to show up, which causes symptoms of palpitations. You can also get sudden cardiac death or even heart failure. Speaking of heart failure, this is a series of patients who needed a transplant for ARVD. This shows age on the vertical axis, and each line is a patient telling their story. And the point is, these are patients diagnosed with ARVD at a relatively young age. Average age of diagnosis was 24. And then 16 years later, at the average age of 40, they required a transplant, mainly for heart failure, because we're pretty good at managing the VT that occurs in ARVD patients. Recently, we've increased this to 1,001 patients and family members, and the results are the same. You don't really see much before puberty. Then arrhythmias dominate as the main symptoms of the disease, and the need for transplant or dying from the disease generally occur in the later stages of the condition. Now we'll move on to management. When you think about management, I think of this five-legged stool. It starts with making an accurate diagnosis, and I've touched on that. Then we have to risk stratify for sudden death. Who needs a defibrillator? Who doesn't need a defibrillator? What kind of defibrillator? That's what we focus on next. Then once the defibrillator's in or not, we want to minimize symptoms and defibrillator shocks. We also want to prevent progression. We know ARVD is progressive and want to stop that or slow that. And finally, we want to screen first-degree family members who may have the genetic abnormality, may be at risk for ARVC, and this gives us a chance to diagnose them early before they die suddenly or have some other problem. When it comes time to making the diagnosis, there's a number of tests. You have to look at the history, physical exam, exercise history, EKG, Holter, echo, MRI. We don't believe in stress tests much. Genetic testing is very useful when you suspect the diagnosis. And again, we rely on the 2010 diagnostic criteria. It's also important to remember that ARVD or ARVC can show up as myocarditis, chest pain, and troponin leaks, particularly in patients with a certain kind of mutation called desmoplakin. Another test we do sometimes is a high-dose adrenaline test, where we drip in extremely high doses of adrenaline. In patients with ARVD, that will light up their VT. You can see all these PVCs, these wide beats and runs of these wide beats. This is a typical behavior of an ARVD patient if they get a high dose of adrenaline as part of their diagnostic workup. So the next step is to risk stratify for sudden death. Who needs a defibrillator? Who doesn't need a defibrillator? There's many variables that are important. History of sudden death or sustained VT. Are you the proband, the first person diagnosed in the family? Are you male gender? What's the extent of the disease? How many PVCs do you have? Have you passed out? Are you going to continue to exercise? What does an EP study show? And then at the end of the day, it's about preferences and values. How much risk are you willing to accept? How much do you want to have the protection of a defibrillator, or do you want to give that up? Now, we've done a lot of research on predictors of arrhythmic events in patients who undergo defibrillator implantation who've never had an arrhythmia before. And this just shows that if you look at these patients who get a defibrillator put in, having never had a sustained arrhythmia, that at 6 years of follow-up, about 60% use their defibrillator. And in about half of those, it's a very fast, potentially life-threatening arrhythmia. So the name arrhythmogenic right ventricular cardiomyopathy is very apt because these patients have many, many arrhythmias. This just shows that things like the results of EP testing separates a high risk and low risk, more than 1,000 PVCs, proband status, non-sustained VT. These are all risk predictors. Now, recently, we worked together with 5 other registries around the world to come up with a risk predictor. So on your cell phone, you can pull out your cell phone and with simple parameters, know what your risk is. And this is the analysis we did, the variables we included. Importantly, male gender increases your risk, younger age, recent cardiac syncope, prior non-sustained VT, the number of PVCs, and the number of leads with an inverted T wave, and also the RV ejection fraction. So this is our online risk calculator, www.arvcrisk.com. If you go to it and you plug in some of these variables, you can find out what your 5-year risk of a sustained arrhythmia is. Now, when it comes time to defibrillator, you get a standard one shown on the left side of this slide, or a subcutaneous one on the right side of the slide. Standard one's been around for about 40 years or 35 years. It lasts about 12 years. Pretty straightforward to put in. The main problem is that lead can break or get infected, and that can cause a problem over time. This can be addressed by a subcutaneous defibrillator that goes outside your rib cage but under the skin. And this device doesn't have the risk of infection and breaking that the one that's put in your heart does. It's not able to stop your VT with pacing. It has to just treat you with shocks. But for many patients, it's the right options. You could talk to your doctor about which one is best for you. So now we want to move on to minimizing symptoms of defibrillator shocks. What can you do about this? One, you can stop exercising, especially stop competitive and endurance sports. Take beta blockers that blunt adrenaline. I showed you earlier what adrenaline does. Take ACE inhibitors if you have significant disease. Consider taking antiarrhythmic drugs like sotalol, flecainide, Ticacin, or amiodarone. We're now doing a study on flecainide. So if you're an ARVD patient, you want to help us understand best treatments, please let Crystal know, and we can see if you're a candidate for the flecainide study. We can also consider catheter ablation if drugs don't work, or if you don't want to take antiarrhythmic drugs. So what about the recommendation to stop exercising? Because most ARVD patients are high-level athletes, and the idea of giving up exercise is very difficult. Well, it's important to know that ARVD is a disease of desmosomal function, and desmosomes hold the heart cells together. And when you exercise, the pressures in the heart, the wall stress in the heart increases dramatically. And as a result of that, you push stress on these bad bolts, and that can trigger ARVD. We also know that sudden death and arrhythmias often are triggered by exercise. There's now 6 or 7 different mouse studies showing that exercise brings on ARVD in a mouse susceptible to ARVD. And now there's many clinical studies from all over the world showing the link between amount of exercise and risk of developing ARVD. This is one of the first classic studies that my colleague Cindy James led. We looked at 87 patients with ARVD, and we looked at how much exercise they did. And we looked at how many hours per year they exercised relative to the chance they got the disease. They all had a mutation that put them at risk. So if you exercise less than 134 hours per year, your risk of getting ARVD was 30% or 28%. But if you exercise more than 500 hours per year, it was 85%. Similarly, if you're an endurance athlete, 82% chance of getting the disease. If you answer no to that question, only 34%. And patients who are highly athletic, who are athletes, have more arrhythmias and have more need for heart failure and transplantation. Again, there was no heart failure in non-athletes, but in athletes, a much higher rate of developing heart failure. Recently, we did another study looking at patients who don't have mutations to see how much exercise it takes for them to get ARVD. And we found that if you're gene elusive, if you don't have a mutation, it takes about twice as much exercise as it does in someone with a mutation. So this is, I think, an important concept. Now, this is a slide of a number of families with plakophilin 2. This shows the patient age on the horizontal axis. Each patient is a line. The number of med hours of exercise is shown, cumulative med hours of exercise in their life is shown on the vertical axis. So this is the proband, the first person diagnosed in the family. From the age of 10 on, they're exercising like a rocket. They exercise 50,000 med hours. By the age of 22, they have VT. They get diagnosed with ARVD. They stop exercising. Here are the siblings, the same mutation that don't exercise are free of ARVD. Here's another even more extreme example. The proband, the one who got ARVD, had done, literally 50,000 med hours by the age of 16, gets diagnosed with ARVD, and eventually stopped exercising. His siblings, which exercise very little, are doing well without ARVD. Most recently, we looked at a paper looking at the impact of exercise restriction on arrhythmia risk after diagnosis of ARVD, and we showed that if you cut back your exercise the most compared to your colleagues, you have an 85% lower risk of developing a sustained ventricular arrhythmia. Okay, a few comments about catheter ablation. If drugs can't control your VT, you can have a catheter ablation procedure where we go in and cauterize it. My colleague, Dr. Tandri, is going to talk more about this. He's a world's expert on it and has very good outcomes and a very good safety profile. But this is certainly a very good option to consider at the right time in the disease. Finally, we want to prevent progression. This is a slide from a study showing that over time, RV function goes down, RV size goes up, LV function goes down, And so this is a progressive disease over time. Don't let anyone tell you it's not. We recently looked at our database to look at how many patients develop heart failure. And we found that over time, 49% of patients with ARVD would develop some evidence of heart failure. So this is important. And if you get heart failure, you're more likely, obviously, to need a heart transplant or to die than if you don't develop heart failure. And this just is shown in this slide. So what can you do to prevent progression? Well, stop exercising or cut your exercise way down. Take beta blockers, those help with arrhythmias, may help with progression. Take ACE inhibitors, same thing for them. So let me just conclude that ARVD is a rare but important cause of sudden death, which is caused by mutations in genes that encode for desmosomal proteins. The diagnosis is challenging, requires a comprehensive evaluation. We see lots of patients here at Hopkins for second opinions from all over the country and all over the world. We always tell patients and physicians, be slow to make the diagnosis because the implications are enormous and you really want to get it right. And we see about 10 ARVD patients a week at Hopkins, so this is something we deal with every day. We now have a risk calculator to help guide, determine what your risk of VT is, whether you should get a defibrillator. In general, we recommend a defibrillator if you've had a cardiac arrest, if you've had sustained VT, or if you're at high risk based on the variables that we've found put in the calculator. Catheter ablation VT is important. If you get in this procedure done, you should get it done at a highly experienced center because it's very complex and can be very risky, except in good hands. It's important to remember that ARVD is progressive over time and that heart failure develops in about 50% of patients over time. So it's really important to cut back your exercise, take beta blockers and ACE inhibitors. And it's also important to remember that it takes a team. At Hopkins, we have heart failure experts, we have VT ablation experts, we have MRI experts, we have EP experts, genetic experts. All of this is important in getting the best care for you, our patient. So I want to thank our staff shown here, particularly Crystal Tichenell, Cindy James, and Brittany Murray, who have been with the program for way more than 15 years and are really the heart and soul of this program. I also want to thank our research fellows as well. And I list some of the other members of the faculty that work with their ARVD patient on this slide, and our many research fellows who've been part of the program, published over 150 manuscripts, and helped move this field forward. So with that, I'll stop, and I appreciate your attention and look forward to a lively discussion later on.